So first off, hi everybody, and welcome to the Canadian Primary Care Research Network Learning Series. My name is Gail Hallis. I'm one of the researchers from the University of Manitoba and the lead for the network here in Manitoba. I imagine most of you might be familiar with this network, but for anybody who's not, the Canadian Primary Care Research Network aims to support patient-oriented, practice-based research that improves primary care. So our mission is to facilitate research, which includes supporting the spread and scale of innovations, building and growing local practice-based research networks, as well as building capacity for primary care research. I'd first like to open our time together here by acknowledging the land from which we join this learning series. As I said, I'm from the University of Manitoba, whose campuses are located on the original lands of the Anishinaabe, Innuit, and Sininewuk, Dakota Wate, and Dene peoples, and the national homeland of the Red River Métis. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Using the chat, I also invite you all to acknowledge and recognize the land where you are located. And I think in our acknowledgement, at least here in Manitoba and Treaty 1, we talk about moving forward in partnership with Indigenous communities. And I think that underscores one of the reasons we're here today at this webinar. All Canadians have been encouraged to walk together with our Indigenous brothers and sisters on the path of reconciliation. And in the Truth and Reconciliation document, many of the calls to action actually require us to continue learning, listen, and seek to understand what Indigenous peoples would like to see happen and how they would like to be engaged or involved in advancing meaningful healing and wellness journeys. So today we come together and we seek to gain insights into strategies that promote Indigenous leadership, meaningful partnerships, and consider research methods to promote equity-based research and inform equity-based healthcare and services that address the needs of Indigenous peoples. So personally, I was kind of the one that said, hey, we need to have a learning session on this because I feel I have a lot to learn, and found out that many others feel the same way. So today marks the third presentation in a three-part learning series that's been dedicated to advancing Indigenous health and the considerations for equity-based research, community voice, and data sovereignty. And today's session is entitled Making Wise Choices, Community Engaged Data Governance Lessons for Primary Care Research. So with our presenters' guidance, we're going to explore this topic. There's several learning objectives around highlighting community experience and the feedback of a particular organization that's really focused on service and data governance. Discuss the critical importance of a relational accountability with regards to knowledge and data, and discuss some of the key principles and paths forward for partnered health systems research. I'm very honored to now introduce you, excuse me, to our presenters. Their full bios are available in the invitation that you received, and I really urge you to read that and become familiar with all the wonderful work they've done. I just want to briefly summarize that Dr. Lindsay Croshoe is a Piikani Nation board member, or pardon me, band member, a First Nations physician, an Indigenous health researcher, associate professor of medicine, and assistant dean at the University of Calgary. His work covers health education policy and programming with a range of local, provincial, and national groups. And his work focuses on improving primary healthcare service for Indigenous peoples. So welcome, Dr. Croshoe. He was to be joined by two individuals, but one is unfortunately not able to join us as he's not well, Dr. Tyler White. So I will introduce Dr. Salim Samanani, who is a medical specialist in public health and preventive medicine with 20 years of diverse and extensive experience working with Indigenous and other marginalized populations. In 2008, he founded OKAKI. OKAKI is a Blackfoot word meaning be wise, and OKAKI Health Intelligence is an Alberta-based public health services, and health informatics social enterprise, that's a mouthful, that works with First Nations communities across Alberta. So he is the OKAKI CEO and medical director, has led complex cross-jurisdictional projects in Canada and several developing countries, and in partnership with communities, government, professional regulators, academia, and the private sector. So wonderful experience. We really look forward to this, and welcome to both of you. I will turn it over to you, Dr. Crochet.
Thank you very much, and good morning, good noon, wherever you're at in Canada. I'll just share my screen now for the presentation, and are you seeing the presenter version or the appropriate version?
Presenter.
Okay, let me shift that. How about
Here.
now? No?
That was the right one, Lindsay, I think, what you were on.
Previous?
Yes,
Yeah.
sorry, the previous one. Yeah, sorry, my mistake, Lindsay.
Okay, so thanks for the intro. I think we will just jump right on in. We provided the session title and description and objectives for you to take a peek at. Over the course of our time together, our aim is to explore this concept of Indigenous data governance. But we will use a narrative approach. We're going to um, tell some in grounded in oral tradition. We're going to tell a host of stories around. I know I told Sal I wasn't going to use storytelling, but I just did. We're gonna tell some stories. We have a narrative approach, and we're going to ask you to think about the concepts and principles that we're working through, and I'll highlight a host of ideas to throw your way, and we'll have a conversation at the end, depending on the amount of time. Just a second here. So Sal, I threw in these slides again at the beginning because I kind of was thinking through that we need to just give the people a bit of a sort of concept to be able to hold on to. And so this slide is to illustrate an American group of Indigenous scholars who are framing and starting to identify concepts around Indigenous data governance. And I just wanted to highlight that the last presentation that you had focused on a Canadian perspective. I'm not going to share those slides and ideas because you had a full session on it. I just wanted to highlight, though, that this is happening all over the world. And Indigenous scholars and people who are working in this space are coming together to make sense of this. So here's a definition for us to hold on to regarding Indigenous data governance. And you likely heard and saw ideas floating around in the last session. So just take a moment to take a look at that. And this international group that I've worked with many of these people over many years. Here's a few slides from a summary of their work. What I want to show you this because it's interesting to me. There's a Blackfoot winter count hide at the top center, which is our way as Blackfoot people of recording the most important event that had occurred for us as a collective, as a community, um, uh, each year. And it starts in the middle and it works its way out. I actually do much teaching and work uh, generated from a Blackfoot winter count in order to show the impacts of colonization and how from year to year many aspects of our life change considerably, and that is information, and information that we hold in a pictograph form, but also as a very rich oral tradition. And on this picture, you see a wampum belt as well from Canada, and on the left a West Coast symbol of knowledge. So the idea of traditional perspectives around knowledge is what we will speak about today. I wanted to share this care principles for Indigenous data governance. So mostly you can see the picture, and one of the individuals in the picture is a person that I've worked with for many years, Dr. Jennifer Walker, third from the left. And so there's an international perspective, set of perspectives in this picture, which I think is important for us to have as a tool. I pulled out half of their framework. This is the care component. So principles for data governance, a collective benefit, authority to control, responsibility, and ethics. And I'll show you the next slide, and I will, if you would like to take a just a screenshot of it, it might be helpful for you to use these concepts as Sal and I share our narratives. So here again, collective benefit, authority to control, responsibility, and ethics. So if you're fast at toggling, um, hopefully you got it. I'm as mentioned, I'm from Southern Alberta. I'm Blackfoot. I'm come from the Piikani Nation. My community was cut in half by the border. So a big chunk of Piikani Nation is in northern Montana, called a misnomer, the Blackfeet Reservation. And on my dad's side, that's where I come from. But my mom is from Siksika. I was born and raised and grew up on both reserves as well as all over Alberta. We moved around a lot, but I wanted to show you that where I'm calling from is Calgary, which is very central in Blackfoot territory as part of Treaty 7, shared with many other nations here. My background comes from the privileges that I've had as a person who had much strong traditions on both parts of the family. On my mom's side, my grandparents were heads of the Horn Society, which is one of the sacred Blackfoot societies, very spiritually focused. And he was also a chief for decades in the 60s and 70s, fighting for Indigenous rights. My grandma was the head of the Motokeek Society, which is a Buffalo Women's Society, which were all instrumental for the host of ceremonies that are core to Blackfoot ways of living and seeing the world. And I grew up having the privilege of being a part of those ceremonies. On the left corner there, you see a snake teepee, which is a teepee that was put up each year at the start of when the bundle was opened, and it would always rain. That was like part of the power of that sort of story there. And on the right side, my grandparents on my mom's side, and my grandma Missy really didn't even speak any English, so we always had interesting, complex conversations. And my name is traditionally Sauki Sapistu, which my great grandmother, Mrs. Buffalo, up there in the right corner, gave to us and transferred to us. Knowledge is brought to us in complex ways, and we have to be bound to it. And a transfer ceremony is a process to connect ideas, concepts, the physical aspects, and the spiritual aspects. And in the middle is a great grandfather who is a spiritual leader of the Piikani Nation, brings down the sun. Down in the middle is the teepee from my father's side. That's the otter teepee, and I'll speak to you about that shortly. The coming back to this actually, there's a story here that's critical that sets the tone for the work that I do. My family, when I first got accepted to medical school, asked me to come down to ceremony, and there was this many conversations over many days in ceremony where my family were quite concerned about the nature of the knowledge that I was just about to receive. They spoke about the ways in which knowledge would come into our community historically. And you can see on this teepee, there's small sort of shapes in the middle of it. Those are otters. And this teepee, for instance, is a very sacred teepee. Not all Blackfoot teepees are painted, but this teepee came to the original owner as a gift from a spirit, the otter spirit. And so this individual would have received this as knowledge that they would have had to come back to the community. You can see that the brown round shapes on the bottom of this means that the individual received this vision in the foothills, and those white dots on the bottom represent us Blackfoot people. We we have this belief we actually come from the stars, and those are markers of our star heritage. And up top, there's the constellation of the sky zone with the rainbow. But anyway, this teepee came to the individual hundreds and hundreds of years ago. But they would have had to come to, say, the Horn Society people to talk about, I've had this vision and it's very powerful and I need to make sense of it. And this type of knowledge would have been vetted through a whole process of decision making we call a kakstaman. And within that, the community would have said, okay, this sounds pretty legitimate. Um, let's accept it as knowledge, because we do agree that knowledge comes directly from the creator. And in this context, they would have done a ceremony, they would have done a transfer ceremony, they would have transferred the concept and the spiritual ideas. And this teepee would have a whole host of stories and a whole host of ceremonial components built in with it that was transferred to the individual, that then is transferred from person to person over decades, over hundreds of years. Um, so that is the concept. The issue is that when my family sat me down, they said, you know, knowledge also comes from other avenues, other flows. And one is, for instance, outside of community. And we've had new ceremonies and new knowledges come to us from other nations, and we fully appreciate it. And it's really important for us to make sense of that. The issue is that that knowledge can't overtake us, and we're worried that your knowledge could overtake us. And that knowledge needs to be properly vetted and explored and understood. Um, the issue here is sitting on the hill. When anybody new came into our territory, you don't just barge right in and take over. You come on, you find a hill close to the community, and you sit there. You light a fire, you set up a small camp, and you wait. And if the community feels that guy knows the protocol, they are being respectful. We'll send out a party of people to say, hey, what's going on here? Who are you? And then you have a exchange and recognize that, yeah, this person here is coming with, good intention. Maybe they're visiting, maybe they're traveling, maybe they have something to share. Then those people go back to the community and say, hey, this is the fellow, he's doing this or she's doing that, and it's all good. They invite the person in. They have a big welcoming ceremony, all of the protocols of sharing and gifting and storytelling and counting coup and knowledge exchange, and then they get down to business. My family recognized that knowledge comes from those processes, and they worried that Western knowledge could overtake in our Blackfoot ways of knowing. And there's a history of colonization and epistemic racism that has undermined our knowledge systems and forcefully displaced by Western ways of thinking and knowing. And so they fully recognize this. So they're super concerned about all of that. They told me that knowledge, if new things come in, you have to sit on the hill and you have to wait, and you have to do this in a way that allows us to have autonomy and then build relationships. So part of the stories that I came to, and that I felt was super important in the way that I came to being a doctor, but also as a researcher, was there's a set of protocols and processes, and there's space and time and breathing, and there's a host of considerations that are required. And in order to start it properly, one has to sit on the hill, and then it's up to our mechanisms and processes to start ensuring things move forward. Um, I'm coming at you as a family doctor who does research, and research that is health systems based, which is primary healthcare based. And I'm the NPI of a network called IPHCPR, the Indigenous Primary Healthcare and Policy Research Network. It's one of the network environments for health research. We're one of 9 CHR funded networks that are designed to build capacity for Indigenous health research across Canada. We fully focus on this concept of primary care. You can see those principles. There's an emblem here that is critical, this butterfly that we choose to use as our sort of grounding concept. And one might think, why, as an indigenous sort of group of research, why didn't we choose a different idea? I often see the bear or a very powerful, emblem or a symbol or an eagle, and it's all good. I asked the team to consider this because it comes from my own community. When I was an early young doc, one of the elders came to me and said that, "Hey, Dr. Crowshoe, um, my butterflies have flown away." And she started laughing, and it was a bit of a teasing joke, but she was testing me to see if I was culturally connected. And like I said, I've had some privileges to have a good family connections to culture and ceremony, but life is busy and we all get busy. And so she was asking me, she was testing me, but nonetheless, the concept is that the butterfly is seen as this thing that allows our knowledge and our dreams to uh, to to come to you while you're in the teepee. So actually, on our teepee, we have this thing at the back, which is called the butterfly apani, and it is the portal for which knowledge and dreams come to individuals. And so we base our framework on this concept of knowledge. So back to the story of my family and their considerations for me when being a doctor that I take as lessons for guiding my career. The another moment in so these are like pipe ceremonies and transfer ceremonies that we would stop and they would have conversations with me, and they would sit me down and say, "Okay, Lindsay," my family would say, "Lindsay, you have to think about this. Um, Wellness and healing comes through relationships, right? And these relationships are critical. But the central relationship is one's relationship with the Creator. And uh, we see Western people stepping over the individual and being very directive. And metaphorically, they're actually standing in the way. They're standing over the person. There's hierarchy, there's power, there's status, and all that stuff. They stand expertise. They stand over the person, and they block that relationship with the creator. And in that moment, that is not helpful, but it also creates conflict and trauma. Um, they would say, "Lindsay, um, so you know the concept of the helper, right? So in our ceremonies, you have all those guys over there, and you've been one. You cut the tobacco, you fill the pipes, you smudge the pipes, you keep the fire going. You bring the pipes back and forth to all of the ceremonial leaders that are in the room at any of the ceremonies. And you're busy, right? Or at the at a Sundance, you're serving people during feasts, you're gifting, all that stuff. But in that process, you're contributing to the society and the community, and you're learning at the same time. So it's service and it's beautiful and it's all good. But you're not above anybody. You're helping. You're helping the ceremonialists. You're helping the people, and the position of the helper and all of us that we have to think about this. He would grab his hand and he would swipe the side of his foot. You're at the foot of the person. Um, Please don't ever stand above the person, and that our role fundamentally as all people ought to be helpers. And to me that was um, a lesson that has allowed me to conceptualize how I position myself in respect to all people, to knowledge, but to supporting other people and things moving forward. So for research, the ideas that knowledge is powerful. Most of my patients, when I work downtown at a clinic that I created like quite a long time ago called the Elbow River Healing Lodge, which is an urban Indigenous healthcare center, and the my patients are quite ill. And when I think about the determinants of that, I see, there's a lot of poverty, right? There's a lot of disconnection from community. I mean, if culture is a modifiable social determinant of health, my patients are disconnected. Um, my patients are disconnected from many resources. One thing that they're notably disconnected from is knowledge. They don't have the privileges that I have, and I think that everybody at this Zoom table has learning the relationship with knowledge that I have that I have had the privilege of by going to university, medical school, and even beyond that to be a researcher. The skills and concepts of a researcher are fundamentally distinct from any of my clinical training. Has created much resilience and wellness, I think, in me, and it's something that I really am it's really important for me to promote one's relationship with knowledge, not just in a really research component, but within my patients. I note that my patients are quite disconnected from learning and the privileges, and it's important, I think, for us to understand this as a concept that the relationship in one's autonomy with many components is central to a larger approach, but is also central to the nature of research and how one comes to knowledge. I think I've touched bases on most of the concepts I wanted to share with you from from this cultural perspective, and I'm going to hand over the presentation to Dr. Samanani. And this slide doesn't show up, Sal.
Yeah, oh, it was there. Just back.
So you see nothing here?
Yeah, and if you hit it one more, it may have had an animation. This is a
Um,
18-year-old, 19-year-old slide. So sorry, it's probably 10 versions of PowerPoint ago. Um, so thank you, everybody. It's a privilege to be here. I'm just digesting Lindsay's story. Sorry, it's the second time I've heard it, and uh, it just brings a lot of thoughts to me as we're making this presentation. I think for me, I'm coming to you. So first of all, I'd like to acknowledge Blackfoot territories I'm on in Calgary as well. Um, I'm coming to you as a practitioner. Again, I appreciated the comment, Gail, that it's practice-based research. I think that's important to me. I come to you as a practitioner who is now engaging more and more in research with research partners. And that is a fairly new and evolving context for myself and for OKAKI. I think this story is really, there's a couple here that were meant to be told by Tyler, and maybe we'll just give you a few minutes of that background. I think the key theme from Tyler is one of, and throughout his career of sort of asserting um, their own sovereignty and their own systems and processes of knowledge, and butting up against really some of the structural and systemic challenges over the last 25 years. I think this story, Lindsay, you can probably start it off because you were quite involved. So the Dr. L is the physician at Sixica. So why don't you're actually the origin story of this. So
Yeah.
Ed.
Um, so there's a physician in Sixica that was there for years. many physicians in my experience uh, have a busy practice, and fee for service generates a ton of money. And so the what we see as in that is physicians that see 40, 50, 60, 70, 80 or more patients a day, considering how much time they have in a very short clinic. This particular physician was of that nature, but the other part of his nature was huge amounts of opioids and huge amounts of benzodiazepines were prescribed, and that there was growing unease in it in terms of quality of care, but risk and ethical issues, and the physician opioid prescribing issue was quite a significant sort of thing and has been and continues to be. But it was quite something that we're trying to make sense of provincially and nationally. But when I came to Siksika as the medical director, I was faced with that this was the nature of this practice. And patients were buying, and they would get their prescriptions, have it filled out in the pharmacy in the health center, and then they'd be selling it right in the waiting room. And we all felt powerless to do anything about this. And so we worked hard to identify a possibility of having this individual removed from the clinic. And we did so with the support of chief and council. So we actually had to go to chief and council and have a ban council resolution to have him removed from the clinic, which created much conflict, because the community was many people in the community, even all the way up to leadership, were his physician, and were getting high quantities of benzodiazepines. And I had just left one community 5 years prior because I was dismayed at the physicians in a rural community south of Calgary who are prescribing huge amounts of benzodiazepines and Tylenol and codeine. And I was seeing these patients in emerge nightly, overdosed, or would need to intubate and send people to the ICU all the time. And I spoke out about this in court, and that ostracized me from that physician group. And Tyler asked me to come on board to support Siksika, and right away I jumped back into this. And so we worked to find an opportunity to have this doctor leave, but it created a whole host of troubles on our part. I mean, the community was pretty upset at us. They tried to fire us many times. Chief and council shifted with the next election with the chief. His platform was to remove Tyler and I from our positions. And we eventually got a death threat, and the RCMP was involved. But I'll hand it over to you, Sal. I set up the story for you.
Well, I think the context at the time, like you can see the date, this is 2006. So this was my second year as a director, as a medical officer at First Nations Inuit Health Branch. And it was my third year working with Lindsay as a clinician. So of note, I have never actually worked with him in a research capacity, and this is our first venture in that 20 years later. But at that time, in Alberta led the country in opioid prescribing and benzodiazepine prescribing per capita. And so this predates the illicit opioid epidemic. Heroin was not a significant concern as it was in Vancouver at the time. And there had been, while I was in government here, multiple judicial inquiries over overdose deaths. And the province had absolutely no ability, no structures, no processes to monitor and intervene with the overprescribing. And one of the things that First Nations Inuit Health Branch has is they administer the non-insured health benefits program, which includes the claims for medications. And so that data had also never been used in a capacity other than to administer claims. It's administrative data, except by a gentleman who's now passed, a physician who worked with us, Dr. Harry Hodes. So I want to acknowledge him. And Dr. Harry Hodes was the first one who sort of got in there and started to try to work with communities to produce profiles, patient profiles on administrative data. And at that time, no province in Canada had a prescription monitoring system. So I think actually that may not be true. Nova Scotia may had a rudimentary one, and there may have been some initial research. And so this was occurring in Siksika, and I think Lindsay didn't say anything, but the physician actually hired a hitman to assassinate both of them. So, this is my foray. This is now my third year working with Indigenous communities, and it was discovered. The RCMP were involved, and it went to court, as Lindsay said. And so we quietly provided him and Tyler data on this physician's prescribing. So this is the three physicians working near Gleason, where Siksika is. And this is the percentage of all claims that were, of all patients that were receiving medications funded by non-insured, the percentage of them actually being prescribed opioids at least once a quarter. So you can see here almost 70% of all clients coming in receiving opioids. So this is just a high level. There was more detailed data, and here you can look at benzodiazepines. Same thing. This is including seniors, over 50% quarter receiving benzodiazepines. And many of your physicians, you understand the risks here, especially in elderly, and a lot of these clients are elderly. And so in court, this data actually was cited and used by the judge in ruling on the case. And so, again, a very tangible example of, in that case, information having immediate relevance and benefit. Now, I'll also note at that time, health information privacy was evolving, the concepts, the legislation. It was not yet clear, that physician information, whether it was considered personal health information or not, these things had not been completely fleshed out. And certainly the legal framework around the federal government was not clear. But there were strong policy documents that explicitly stated a fiduciary responsibility to make sure that prescribing is safe. And these were articulated in the federal policy document. So we felt, even though I was a little bit more naive and maybe reckless, we did feel there was a ground on which to facilitate the exchange of this information. But I guess at the heart of this is, is it our obligation to provide this information? Should we have provided this information? Is it our duty? Is it our duty? Or are we doing it? In what role are we doing it? So there was a lot of questions here and hand-wringing through this process. As a side note, this is the origin story for Alberta's prescription monitoring program. So I won't bore you with the details, but you go forward 20 years, and OKAKI currently built and supports Alberta's program, and we get 60,000 dispenses nightly on a variety of controlled drugs and medications, and we support all of the regulators, and every physician in the province now receives prescribing snapshots as part of their audit and feedback and self-practice. So, an example of something that really was needed broadly, and that started here. Lindsay, maybe the next one. I don't think you're aware of this one, but I'll talk about back one. Yeah. So this is an interesting story that Tyler really. I'll try to capture um, his perspective here. Is in their original health center. Um, they used to maintain a physical paper book called the Death Book. I think this is the I don't know if this is the Blackfoot word for the project or for the book. I think it was for the book. And um, this was a documentation of every time there was a death in the community and it had gone back really decades and decades. And there was a description of the cause of death, and they maintained this. And also at the time I was in the federal government, um, Tyler wanted to delve into this. And, as a public health physician and coming from an epi background, to me, this was sort of just vital statistics. And you just, crank the numbers, you look at death rates, you present it to people. And I have never actually, I can say honestly, I have never actually seen vital statistics presented in our traditional form. Um, I've never seen it have an impact in any programs tangibly. Maybe along with other data, but this is not something that I have actually seen translate into action. And what was remarkable here was actually the process of turning this into consumable, digestible knowledge and leading to action at the community. So it's not about what was in the book, it was the process of how this book was transformed again into knowledge. And so a committee was formed. It included many elders who were sort of the most senior members and key members of societies in the community, as well as some technical people, and we coupled it with epidemiologic a position. Actually, it was a field epi program that staffed this. That was jointly stationed with Alberta Health and Indigenous Services, or at that time First Nations Inuit Health Branch, Health Canada. And the interesting thing about this, and this is where a person, again, I want to acknowledge Larry Svensson, who is now passed, a legendary public health figure in Alberta. And he sort of led the analytics and health system analytics and epidemiologic group in Alberta Health. Larry and I co-supervised a student, and he was very, again, flexible and open in letting the community take the lead and providing support by taking this book and linking it to true provincial vital statistics and providing a deeper analysis of this and returning it to the community for discussion. And so there was this iterative process that went on for a few months. And in the process of it, it actually uh, allowed people to look at the influences that had changed um, over decades, including the introduction of alcohol and the impact it had, and injuries and other forms of disease. And through those stories and through those discussions, the report of this is actually quite incredible, is they contextualize every decade through the social factors that are happening. And a lot of this is oral. So yeah, you're seeing charts, you're seeing numbers, but what I'm hearing is actually the discussions around this. And this tangibly led to actually the first time that Tyler would have, and again, look at the date, where they would have said, you know what, and many of you may not be familiar with funding agreements, but the basic funding agreement from Indigenous Services that funds programs and services is very prescriptive, and there's progressive levels of transfer that give more and more autonomy to communities. At that time, this was not common, and most agreements were very prescriptive. And that is the first time where I think Siksika came back and said, you know what, well, we don't like your plan. This is going to be our plan. and our plan is going to be based on our death book. And so again, a very powerful process. Okay, I'm getting a little hint from Lindsay that it's you better move it along here. Okay, the session, you're right. Oh my God. Fast forward. All right, we had the introduction here. So this is just a map of all the First Nations in Alberta. So I'm going to tell you a story, and the black spots are all the health centers where we currently support all the data infrastructure. That is for nursing programs and for allied health professional programs. So they do not include, physician primary care. Next slide. So I'm going to tell you a story that's actually, I'm going to go fast, that's quite dear to me. I think we can skip this, Lindsay. And that is on immunizations. I'm a public health professional. Obviously, it's relevant to me for there. You all understand that the importance of this just coming out of a pandemic, and now we have a national measles outbreak. But immunizations is important for other reasons. These links may not be valid anymore because these slides are archaic. But at the time, if you looked at any healthcare quality report card in the world, they always included a fair number of immunization rates as a measure of quality. Next slide. If you looked at immunization rates across social strata, immunization rates reflected disparities in access to healthcare. And so, immunizations have relevance for many reasons, and they happen to be considered a mandatory program, which means every First Nation is required to deliver these immunization programs. Next slide. So, what's the experience in 2009? So, first of all, I want to say that there was zero collaboration between provincial health services, at that time regional health authorities, and reserve services. Like nothing. And they did not want to. Things have changed, but that was the context. First Nations had the only paper-based records in the province. Kids were constantly on the move, and not just kids, family members between communities on and off reserves. Only about half of reserves had elementary schools. Only about a third had high schools. And so even if they lived on reserve, they went off reserve for school, and off reserve, all immunizations are given by provincial health services. On reserve, they're given by First Nations health services. And this is unique at this time because the federal government actually procured their own vaccine and could deviate somewhat from the provincial schedules. And so if this was, and I came into this picture in 2005. And for 4 years here, up to H1N1, I'm trying to wrap my head around what's going on. And I think it's an absolute disgrace. Like I cannot understand how we can run a program. I'm trying to get to know community health nurses, and they're spending half of their time trying to get records. Provincial, half of the public health units off reserve won't even send them records without patient consent because they didn't acknowledge that they were professionals in the same respect as another public health unit. So another public health unit off reserve phones for a record. First of all, they don't need to because the records are electronic. But if a physician phoned, no problem, no consent required. It was recognized as a circle of care. But if a First Nation public health nurse calls, you need patient consent. And so lots of missed opportunities if you're waiting for the records. If you're not waiting for records and you go ahead, lots of unnecessary doses. Nobody is checking rates more than once a year, and just forget about outbreaks. This picture, by the way, is a picture of off-reserve Albertans, rural Albertans, lining up at Siksika Health Center in 2009 to get vaccine because they were the only ones who had vaccine available at the province at the time. And just imagine every one of these records is a piece of paper, and every dose has to be publicly accounted for. So you can just imagine the record nightmare. Next slide. So, here at that time, it was established that First Nations had 6 to 8 times the rates of vaccine preventable diseases. And, the next point is why? And it was just amazing to me that you never heard a plausible explanation being because there's low coverage rates. And I just didn't understand that. And in fact, the rates presented by one of my colleagues who oversaw that program were quite high. And I'm just going, what's going on here? And when you dig in and you start to look at the reporting process, you realize, and you talk to the nurses, most of them are just estimating it. And they're doing that on a subset of clients they see that they know they can follow, but it's certainly not everybody and everybody in the target age groups because there's so much movement. And once you get beyond 30 or 40 babies a year born to a community, there's no real way you can track this. And so like the reason is vaccines work, and these theories that there's immunological differences and genetic differences. I mean, I'm not disputing that there may be some, but it's not why there's 6 to 8 times the rates of vaccine preventable diseases. The reason is that there must be low coverage rates, and and it's obvious that there's low coverage rates because there's no incomplete records and there's no reminder recall systems, and these are so basic. um, this has got to be the explanation. So go next slide. So really, this is the mission that we set out at one of the founding. It's one of the things we are still focused on today is quite simply, we want every person in Alberta, not just Indigenous person, to have a complete immunization record. We want to achieve and optimize the highest coverage rates. And more importantly, what was alarming to me is the sense of acceptance that this was the way it was going to be, and there's just nothing we could do about it. Like, I think for me, it's actually about the last point that just the attitudes and again, the acceptance of something that's clearly not okay. And there was just nothing that could be done, and so people just accepted it. And certainly 3, 4 years in government, I tried my best to change this, and then leaving government, and we just could not break through all of the challenges. And so finally, next slide, what did it take? It took two communities to say enough is enough. And I have to say, one was a veteran nurse who just had enough, and she wanted to she was tired of waiting and being in the current circumstance. And the other one was a new nurse manager who probably was just naive as to what it would take to do this, and jumped in. And we were a technical helper. And there were a lot of issues to think about. Well, if we're going to do this right, there has to be a client registry where we have one person who can be followed anywhere in the province that they are. We had a lot of computer illiteracy, like 30% of the workforce had never even used email at the time on reserve. There was absolutely no literacy around privacy and no supports, unlike for physicians. There was tons of paper records, and you couldn't really exist in a paper and digital world simultaneously with immunizations because you need a complete record. So there were many, many issues and challenges, and what we tried to do was just support the process and make it easy to do this. It was already courageous, and I can tell you, having been in the system, it was incredible how much resistance there was to this community standing out. So I'll speed up again. I want to show you one slide. Go ahead and next slide. Next slide, Lindsay. I'm just looking at the time, so I'll jump ahead. I'm going to speak to two. So Treaty 6 is a special treaty. It's the Medicine Chest Clause. And there's a tribal council in central eastern Alberta called Tribal Chief Ventures. And very politically active, and not fearful of exerting their sovereignty. So at the time I went there, they basically informed the government, we are also moving forward with electronic records. They are our own. We expect your support. And by the way, there's been legal changes that allow our nurses the same authorities as others to access records. Next slide. And then no, crickets from the government. Yeah, next slide, Lindsay. Sorry, back, you had done it. So one of the communities actually maintained, so you have band and you have federal nurses. One of the communities actually had a federal nurse who was directed by her superiors to not use the record system. So even within the health center, there were um, there were paper records by the federal nurse and electronic records. So two record systems within the same health center for clients. You can just imagine that. So the chiefs called it out, and ultimately that action led them to reverse their policy or their directive, which was a silent directive anyway. Lindsay, let's go ahead to the second set of coverage rate slides. So I want to go ahead to keep going. Yeah. I want to go ahead. Yeah, keep going. And right here. Oh, stop here. So we talked about no coverage rates. And so one of the things we did is when we reached 1,000 children, born across 18 health centers, we said, let's look at the real coverage rates. And the good thing about young children under 1, under 2, if they're born on reserve, for the most part, they're getting their immunizations on reserve. They haven't gone off reserve for school yet. So they're reasonably accurate. So this is an on-time coverage rate that shows the 4th dose in a primary series of diphtheria. And in an ideal world, you're reaching 95% of kids will be immunized when within a month of being eligible at 18 months. So you will see this graph shoot up from 18 to 19 to about 95% and then go across. And that's a really good, well-run program, a high-quality program. This is showing 5 birth cohorts of 1,000 kids, and we don't even have 50% coverage rates. And so let's go ahead, Lindsay, fast forward 4. And Jeff, 4 slides, go right to the 4th one. So this is a slide of Sixica, and you can look at now, it has 6 birth cohorts. And the last cohort, 2012 cohort, was the first cohort that all they did was print a list once a month of kids who were due and call them. That is literally all they did, is once a month they pulled a list of kids who were due and called them. So all this took was having a reasonably complete electronic records and a means to generate a list. And so, I understand that research often delves into, many complex issues, and Lindsay particularly loves to talk about complexity. But for me, sometimes I say, well, the answer is actually really simple. We just have to get out of our own way and support people to do what they need to do. I think I'll just end there because I'm sorry I took so much time. I blame you for taking too long, Lindsay.
Well, thank you both, really. We are a minute until the end, but I mean, what has been super clear to me is the importance of what you just said, the simple questions and how to translate that into knowledge that is useful and relevant. I think one of the things that's clear too is that we need to make more space for these kinds of conversations to happen and to continue. So we will work on that. I would really like to see you come back again. The other thing I think is that Dr. Croshu, your Indigenous Primary Healthcare and Policy Research Network, and how we come together with the Canadian Primary Care Research Network is going to be exciting stuff. And that's something that another pathway for us to follow. So thank you both, Dr. Croshu, Dr. Samanani, for giving us your time and your insight today. And this, unfortunately, at this moment, just wraps up our 3-part learning series. And hopefully we can continue this conversation. I also want to think about some of the key learnings that we've had here throughout this learning series. and stress the importance of us to continue to learn, to reflect on what the speakers have shared throughout the series, and to perhaps prepare ourselves better to put ideas into action. And on that note, I just want to say that we are having all of these presentations available. Absolutely go back and revisit what we heard, think and reflect further on what we've heard. The end of this learning series, we're taking a hiatus for the summer, but we're back again in September. So we're going to have another learning series that will be hosted by the University of PEI. So please stay tuned. Thank you all for joining us. And once again, Dr. Croshu, Dr. Samanani, thank you so much for your time and for presenting all of this very insightful and important information today.
Apologize for not allowing time for questions, but happy to take questions if people want to shoot them our way. And thanks very much for the privilege.
You'll be hearing from me.
Bye-bye.
That's great. Thanks. Bye-bye.
Hey, Lindsay, before you go, I was just looking at something that might be useful for us, a Catalyst grant.